Good day, future doctors. So for today, we will be talking about immunodeficiency disorders. Before we'll discuss the different immunodeficiency disorders, let us define them first. Immunodeficiency disorders are the overt failure of the immune system to generate an immune response, which will greatly affect the ability of an individual to resist an infection. Now, as a future medical practitioner, what should give you a clue that a patient could be having an immunodeficiency disorder? Number one, there is increased frequency of an infection. So most likely you will encounter a patient who would always go back to your clinic complaining of recurrent type of infection in his or her body. So that should raise a suspicion of a probability of an immunodeficiency disorder. Number two, they can present with increased severity of infection. What is mild in an immunocompetent individual could be deadly to someone with immunodeficiency disorder. And sometimes, immunodeficiency disorder would also present with reactivation of a latent infection. And I will give you an example of this one for you to understand. These are plaques of oral thrushes or oral candidiasis. In an immunocompetent individual, you might see one or two of them in the oral cavity. But for someone who has an immunodeficiency disorder, you'll get to see multiple plaques of oral thrushes distributed on the oral cavity. It's so severe that the infection will even extend up to the esophagus. One oral thrush is already painful. So just try to imagine if you have multiple oral thrushes on your oral cavity down to your esophagus. How painful could that be? Immunodeficiency disorders can cause reactivation of a latent infection. And a good example is the reactivation of the latent infection with Varicella virus. Varicella is the viral causative agent of chickenpox. Chickenpox is acquired through direct contact or inhalation of aerosols from the respiratory tract of the infected individual. When you acquire chickenpox, you will develop fever and there would be the appearance of the vesicular lesions on your skin. When you say vesicular skin lesions, these skin lesions are fluid-filled. Chickenpox is a self-limiting disease. Eventually, the person will recover from it. Varicella infection or chickenpox is a self-limiting disease. The patient will recover from it even if the patient will not be given antiviral therapy. What we do as doctors is that we just do symptomatic treatment. If the patient will have fever, we'll give antipyretic or paracetamol. If the patient will complain of pruritus on the areas where there are rashes, then we will give the patient antihistamine. Now, I want you to take a look at the photo. You have there the fluid-filled lesions or vesicular lesions on the skin. As soon as the patient will recover from chickenpox, the virus is not actually cleared from the body. The virus will stay dormant or latent in the dorsal root ganglion. Do you know that stress and immunocompromised states will cause the virus in the dorsal root ganglion to be reactivated from its dormant or latent state? And this virus will travel through the nerves and will cause the appearance of skin lesions on the skin where the nerves are actually distributed onto. These skin lesions are also fluid-filled, but you will no longer refer to them as chickenpox skin lesions. You will refer to them as herpes zoster or shingles. This time, the skin lesions are very, very painful because They basically involve the nerves where the virus are transported into from the dorsal root ganglion up to the skin. These are the pictures of the skin lesions of shingles or herpes zoster. They are fluid-filled and they tend to follow the distribution of the nerves involved in the spread of the virus from the dorsal root ganglion up to the skin. So if the skin lesions will be in a dermatomal pattern plus the fact that they are fluid-filled and painful, that's the time you get to diagnose the patient to be having shingles or herpes zoster. But the main point that I want you to understand from this discussion is that immunodeficiency disorders can cause the reactivation of a dormant or latent infection. These are other sample pictures of the herpes zoster or shingles skin lesions. These are very painful skin lesions that even a blow of air into these lesions can initiate tenderness or pain. Immunodeficiency disorders would particularly involve certain components of the immune system. What do I mean by that? There are immunodeficiency disorders affecting the phagocytes only. There are immunodeficiency disorders that are affecting T cells only, B cells only, or there are immunodeficiency disorders that can affect both T cells and B cells. But the point is, immunodeficiency disorders can be a defect in one or two of the components of the immune system, and they can be classified as primary or secondary. Primary immunodeficiency disorders are also known as congenital immunodeficiency, meaning the person who has the disease was born with the disease. Why? Because this group of disorders are genetically determined, meaning there is mutation in the DNA of the individual or problems with the chromosomes of the individual leading now to the occurrence of the immunodeficiency disorder. So expect that this one can also be passed on from one generation to the other. Most of the time, primary immunodeficiency disorders would have their manifestations of signs and symptoms between 6 months of life up to 2 years. Remember, we are protected by the maternal antibodies that cross the placenta for the first few months of our lives. I'm talking about the IgG. Now take note of this. In the USA, approximately 1 out of 500 individuals, 1 out of 500, take note of this, are born with defects involving components of the immune system. But majority of them are not diagnosed. Why? Because only a small proportion of these individuals born with defects involving the components of the immune system would develop life-threatening complication. Patients with cancer, especially leukemia, can also become immunocompromised. Leukemic cells proliferate rapidly, and they can occupy majority of the space in the bone marrow. Thus, the bone marrow will stop producing the other white blood cells. Thus, the patient will become immunocompromised. Malnutrition can also cause some patients to become immunocompromised. Remember, antibodies are proteins, and proteins are made up of amino acids. And one of the sources of amino acids is our diet. So if there is malnutrition, expect that we won't have enough amino acids to form the antibodies. These secondary or acquired immunodeficiency disorders may occur at time in life depending on the exposures to the environmental causes. Remember, The principal consequence of having an immunodeficiency disorder is the increase in the susceptibility to infection compared to immunocompetent individuals. Now, you have to take note of the following. Immunodeficiency disorder involving the B cell or the humoral immunity would present with recurrent infections with capsulated pus-forming bacteria and some viruses. Why? Remember, capsulated bacteria are best dealt with opsonization. And one of the known opsonins is IgG. IgG is an antibody, and antibodies are produced by B cells. Viruses are also neutralized by antibodies. So if you have a problem with B cells and there is low or no production of antibodies, most likely you will have increased susceptibility to infections caused by capsulated bacteria and some viruses. Defects involving the cell-mediated immunity or the functions of the T cells will most likely present with recurrent viral infection, recurrent or severe infections with intracellular bacteria. Remember, viruses and intracellular bacteria are killed by T cytotoxic T cells with their interaction with the infected cells via the MHC class 1. So if you have a problem with the number and function of your T cells, most likely you will have recurrent viral infections or recurrent and severe infections with intracellular bacteria. Some patients with defective T cell function would have increased susceptibility to cancers caused by viruses, and they would also have reactivation of latent infections. Combined immunodeficiencies of T cells and B cells or the humoral and cell-mediated immunity will most likely make the person susceptible to infections by basically all microorganisms. Immunodeficient individuals usually present with infections with microbes. Take note of this, that are commonly encountered but effectively eliminated by a healthy person. What is mild to an immunocompetent person may be severe and life-threatening to an immunocompromised patient. Primary immunodeficiencies can affect different components of the immune system. We have the phagocytes, we have the T cells, we have the B cells, we have combined T and B cells, and we also have immunodeficiency disorders involving the complement proteins. Let's start with the primary immunodeficiency disorders affecting the phagocytes. And we have the following: Chediak Higashi, chronic granulomatous disease, Myeloperoxidase Deficiency, leukocyte adhesion defects 1, 2, and 3, and we have interferon gamma receptor deficiency. Let's start with Chediak Higashi syndrome. Chediak Higashi is an autosomal recessive disorder, meaning you need to inherit two abnormal genes from your parents for you to manifest the signs and symptoms of this disease. And this basically involves the mutation in the LIS gene. The LIS gene encodes for the LIS protein. LIS stands for lysosomal trafficking regulator protein. And how important is this protein? It facilitates the transfer of melanosomes from melanocytes to the keratinocytes in the skin. In the absence of lysosomal trafficking regulator protein, melanosomes are not transferred from melanocytes to the cells of the skin. Thus, there is reduced pigmentation in the skin, resulting to albinism. There is also a problem with the transport of enzymes from the Golgi apparatus to the lysosomes. So the lysosomes of phagocytes will not contain digestive enzymes. thus affecting their ability to kill engulfed or phagocytosed bacteria, resulting to immunodeficiency. And patients with Chediak Higashi will also have a high tendency to bruise and bleed because of the involvement of the platelets. Let us now discuss the importance of the lysosomal trafficking regulator protein to our phagocytes. Take a look at the purple-colored lysosome in the picture. Lysosome is an organelle that is known to contain powerful digestive enzymes. These enzymes are not produced in the lysosome. Enzymes are proteins, and proteins are synthesized in the rough endoplasmic reticulum, and that's the pink organelle at the 6 o'clock position of the photo. The enzymes produced by the rough ER are initially immature and non-functional. That's why you can see in the picture that the enzymes are then transported to the Golgi apparatus for further processing and modification. Once the Golgi apparatus will process and modify this enzyme, these enzymes now are transported to the early endosome. That's the early form of our lysosomes. And what will allow the enzymes to go inside the early endosome so that they will become part of the lysosome later on is the lysosomal trafficking regulator protein, the absence of which will result to lysosomes with no digestive enzymes, thus affecting the ability of the phagocytes to digest engulfed bacteria. Take a look at these two lysosomes. One has lysosomal trafficking regulator protein expressed on its surface, while the other one does not. So which among them do you think will contain powerful and active digestive enzymes? It's the lysosome with the lysosomal trafficking regulator protein. This is the whole process of phagocytosis. You have here one microbe that is engulfed by the phagocyte in steps 1 and 2. After the completion of step number 2, the organism is then enclosed in a vesicle, which we will refer to as the phagosome. The phagosome is not designed to kill the engulfed material or bacterium. That's why in step number 4, the phagosome should fuse with the lysosome so that the lysosome can use its enzyme to kill the engulfed microorganism. In people with mutated lysosomal trafficking regulator protein, their lysosomes do not contain digestive enzymes. Do you know that the LYST protein is also important in the fusion of the lysosome to the phagosome to form the phagolysosome? So there are two things that are altered in cases of Chediak Higashi. Number 1, their lysosomes do not contain powerful digestive enzymes. Number 2, their lysosomes will not fuse with the phagosome to form the phagolysosome and initiate digestion. I have already discussed bullet number 1 from the previous slide. I also want you to take note that LYST protein is also important in the maintenance of secretory granules in different types of cells, particularly platelets. If there is a problem with the maintenance of the secretory granules of platelets, platelets will have problems with their functions. Thus, there is an increased tendency to bruise and bleed. I will discuss this one in detail later. Another important thing I have found out from my readings is that lysosomal trafficking regulator protein also functions to maintain the size of lysosomes. So if there's a problem with LYST, the lysosomes now will somehow become bigger than normal lysosomes. Recurrent infections by Staphylococcus and Streptococcus organisms are frequently seen to patients with Chediak Higashi syndrome. Staphylococcus and Streptococcus bacteria normally infect the skin and the upper respiratory tract. So expect that patients with Chediak Higashi are susceptible to frequent bacterial infections involving the skin and the upper respiratory tract. The lysosomal trafficking regulator protein is involved in the transfer of melanosomes from the melanocytes to the keratinocytes of the skin. These melanosomes contain the pigment melanin. If melanosomes are not transferred from melanin to keratinocytes, there would be what? Decreased pigmentation of the skin, resulting to albinism. So this is a picture of a patient who is a diagnosed case of Chediak Higashi. Take a look at the hypopigmentation of the skin and the hair. Patients with Chediak Higashi will also manifest with ocular albinism. So they will not have that brown pigmentation in their pupil. This is the anatomy of the eye. The outermost layer is called the fibrous layer. It is composed of the anterior cornea and the posterior sclera. The second layer is called the vascular layer. So we will identify the parts that belong to the vascular layer. Let's start with the structure that is found at the posterior part of the eye, the brown-colored choroid. The choroid will dilate at the anterior part of the eye to form the ciliary body. And this ciliary body will have an extension that will partially cover the lens. And that extension is called as the iris. Do you know that the choroid, the ciliary body, and the iris would appear to have brown colors under H&E staining? Why? Because these structures contain melanin. Red arrow is pointing to the lens, and partially covering the lens, the structure pointed by the blue arrow, is the iris. And take a look at the inferior portion of the iris. You have there a dark staining area, and that basically contains melanin. In the absence of lysosomal trafficking protein, you will have hypopigmentation on the iris. Thus, the patient will have ocular albinism. Lysosomal trafficking regulator protein is involved in the maintenance of secretory granules. Our platelets contain secretory granules. A good example is the platelet's dense granule. The dense granules of platelets contain ADP and serotonin. In the absence of lysosomal trafficking regulator protein, the platelet will have a problem with storing and releasing ADP and serotonin. What is now the importance of ADP and serotonin in the function of the platelets? And that's why they have to be stored in the dense granules. Whenever we are wounded, the body has to do something to stop the bleeding. And the mechanism that will lead to the cessation of bleeding is called hemostasis. Hemostasis has 4 important steps, but I will only highlight the first 2 because they are the ones related to our topic. The first step in hemostasis is vasoconstriction, and it functions to limit the blood flow to the injured area to not cause further blood loss. This vasoconstriction will be followed by primary hemostasis. This is the second step, and this is primarily mediated by the function of our platelets. As you can see in the picture, you have there the yellow-colored platelets aggregating so that they can form a platelet plug and not allow further blood loss. This primary hemostasis starts with platelet adhesion. You have individual platelets binding to the wall of the damaged blood vessel. And this is primarily mediated by the glycoprotein 1b on the surface of the platelets and the von Willebrand factor displayed by the damaged endothelium or blood vessel. adhesion of platelets is not enough to cause the cessation of bleeding. That's why platelets have to recruit more platelets towards the area so that they can aggregate. And for these platelets to call out more platelets, they need to undergo platelet release mechanism. So platelet adhesion is followed by platelet release mechanism. And what are released are ADP and serotonin from the dense granules. After the platelets are recruited by the ADP molecules and serotonin, the platelets now will aggregate and form the platelet plug. People with Chediak Higashi syndrome cannot maintain their dense granules. Thus, their platelets cannot store and release ADP and serotonin. Platelets will not be able to form the platelet plug. Thus, these patients will have increased tendencies to bruise or to bleed. Chediak Higashi syndrome is most of the time diagnosed clinically, meaning the doctor doesn't have to rely heavily on laboratory tests just to diagnose the patient. The physician can just simply use the medical history and physical exam findings of the patient. Medical history would reveal possible relatives or family members having the said disorder. Medical history can also reveal recurrent infections and increasing severity of infections involving the skin and upper respiratory tract. Physical examination findings would reveal albinism, ocular albinism, and possible signs of bleeding such as gum bleed and presence of bruises in the body. So with all of those information, the physician can come up with a diagnosis that the patient could be having Chediak Higashi. In the laboratory, medtechs can help in the diagnosis of Chediak Higashi because they can check this one on the peripheral blood smear. But first, take a look at the picture of a normal neutrophil. And this is how the neutrophils of someone with Chediak Higashi syndrome would appear under the microscope. Please do appreciate the presence of giant lysosomes. Remember, one of the functions of the lysosomal trafficking regulator protein is to maintain the size of lysosomes. So take a look at the lysosomes of the two neutrophils on the right photo. They appear to be larger than normal. Thus, that is highly suggestive of Chediak Higashi syndrome. Let's have a summary of the Chediak Higashi syndrome. The problem is on the mutation of the lysosomal trafficking regulator protein. This protein is important in the maintenance of the dense granules of platelets. Dense granules function to store and release ADP and serotonin. And these two molecules are important in the recruitment of platelets so that they can aggregate and form the platelet plugs. The absence of this protein will cause easy bleeding and bruising. This protein is also important in the transport of enzymes towards the early endosome and lysosome, and the fusion of the lysosome to the phagosome to form the phagolysosome. The absence of protein will affect the ability of the phagocyte to digest the engulfed bacteria. Thus, the patient will become immunocompromised. And according to some of my readings, some patients with Chediak Higashi syndrome will present with peripheral neuropathy, and the only explanation that they provided is that the lysosomes in the neurons are defective in the absence of lysosomal trafficking regulator protein, thus causing the neurons to die, and the patient will have peripheral neuropathy. There is no specific treatment to Chediak Higashi syndrome. The important thing is, once the patient is identified to have this condition, you always have to manage the infections with antibiotics because you cannot just simply rely on the immune system of the patient to fight off the microorganism. Bone marrow transplants have been shown to be successful in some patients. Then, there's also a proposal to try gene therapy. What is gene therapy? Gene therapy will make use of viruses. What will the scientists do is that they will remove the nucleic acid components of these viruses so that if they will be introduced into the patient, they will not cause the patient to become sick. Then, they will replace the viral nucleic acids with the gene that encodes for the lysosomal trafficking regulator protein. You know very well that viruses can invade cells. That's the reason why they are the ones that will be used as a vehicle to transport the missing gene to the patient. So, you have a virus with the normal LYST gene, and this virus will be introduced into the body of the patient with Chediak Higashi. Expect that this virus will now enter the cells of the patient, and they will insert into the genetic makeup of the patient the missing lysosomal trafficking regulator protein gene. And the patient now will gain the ability to produce lysosomal trafficking regulator protein. And that's gene therapy. The second primary immunodeficiency disorder involving the phagocytes is chronic granulomatous disease. Chronic granulomatous disease is an X-linked disorder, meaning this will manifest most of the time in males, while females will act as carriers. Because in females, they have two X chromosomes. If one would have a missing or mutated gene, the other one can compensate. In the case of males, they only have one X chromosome. So if that X chromosome has a mutated DNA, the Y chromosome cannot compensate for that. Now, what is the problem with chronic granulomatous disease? There is that missing gene that will form the NADPH oxidase complex. You know very well that this NADPH oxidase is important in the generation of the toxic oxygen radicals which the phagocytes can use to kill aerobic bacteria. That's why patients with chronic granulomatous disease are at increased risk of developing life-threatening complications or infections with catalase-positive bacteria because these bacteria are best killed with toxic oxygen radicals which the patient cannot produce because of the absence of the components of the NADPH oxidase complex. How important is NADPH oxidase? It helps the cell to produce toxic oxygen radicals such as hydrogen peroxide and hypochlorite. Just take a look at the chemical reaction. Oxygen is made to react with NADPH with the action of this enzyme, NADPH oxidase. And one of the products is superoxide. Superoxide will proceed to the second reaction that is facilitated or catalyzed by superoxide dismutase. And with that, there is the production of hydrogen peroxide, which can kill a lot of bacteria. But the thing is, for this hydrogen peroxide to be produced, you need the superoxide substrate. And superoxide substrate is derived from the first reaction, which is catalyzed by NADPH oxidase. So the absence of this enzyme brought about by the genetic mutation will now impair the ability of the phagocytes to produce hydrogen peroxide. Thus, there's a problem with killing aerobic bacteria. This is the whole NADPH oxidase complex. As you can see, you have their different subunits. You have the GP91 FOX, the P47 FOX, and the rest. Plot twist. Chronic granulomatous disease Yes, as mentioned a while ago, is an X-linked disorder. But do you know sometimes it can also be inherited in an autosomal recessive fashion? If the protein that is missing or the subunit that is missing is GP91 FOX, then it's the X-linked form of chronic granulomatous disease. So it will most likely affect young boys. The absence of the other subunits, the P47, the P67, are the autosomal recessive forms of CGD or chronic granulomatous disease. The primary organ affected in chronic granulomatous disease is the lungs. Remember, this disease is characterized by the inability of the immune system to eliminate aerobic microorganisms because there is no production of toxic oxygen radicals. The lungs have high oxygen concentration because that is where gas exchange would usually take place. And this high oxygen concentration can promote growth of aerobic microorganisms. And what prevents the growth of this aerobic microorganism is the presence of the alveolar macrophages in the lungs. In people with chronic granulomatous disease, their alveolar macrophages cannot eliminate these aerobic microorganisms because they cannot kill them using toxic oxygen radicals. So what will happen? The oxygen concentration in the lungs can now promote the growth of aerobic bacteria, and they can also support the growth of molds. That's why patients with chronic granulomatous disease would complain of recurrent bacterial pneumonia. Some of them would also complain of recurrent fungal pneumonia, especially if they are exposed to dead materials such as hay and dead leaves which contain molds. Molds kasi are generally aerobic. Okay, that's why they can survive in the environment because there's plenty of oxygen there. So what will happen? If we inhale the spores of these molds, okay, the molds can actually grow in the lungs if they are not killed by the alveolar macrophages. I want you to take note that a lot of patients with CGD would also report having recurrent abscesses in their lungs, in their liver, and the skin. And the reason why this disease is called chronic granulomatous disease is because the patients will develop granulomas in different organs in the body. And you know very well from histopath that once there's granuloma formation, this granuloma will increase its size. This granuloma will replace the normal cells of the tissue, okay, thereby causing damages and destruction. And eventually that will lead to the failure of the organ to perform its function. We have here in this picture a group of aerobic bacteria. One of them is engulfed by the phagocyte. If the phagocyte has all the subunits of the NADPH oxidase complex, then that phagocyte can generate toxic oxygen radicals and kill the microorganism. But in phagocytes with missing subunits of the NADPH oxidase, killing is not possible, and that will lead to granuloma formation. How? The neutrophils of patients with chronic granulomatous disease have impaired ability to eliminate aerobic bacteria. Thus, the infection will become chronic. So what will happen? Eventually, these neutrophils will be replaced by the brown-colored monocytes or macrophages in the picture. But since these monocytes or macrophages also don't have the complete NADPH complex, they will also fail in killing the microorganism. And what will happen? That area will be later crowded with recruited macrophages, causing now the formation of granulomas in the different sites of our body. Take a look at this liver. The light staining areas are actually growing granulomas. This is how the granulomas would appear under the microscope. Please imagine, as long as the organism is not eliminated, these granulomas will continuously grow in size. And as they do so, they will replace the normal tissue and cells of the organ, affecting now the function of that organ. To diagnose CGD, we can request for Nitroblue Tetrazolium test. This dye is a colorless dye. Once oxidized, it will turn blue. Now, we will expose neutrophils to Nitroblue Tetrazolium dye. If the neutrophils have complete subunits of the NADPH oxidase, then they can produce hydrogen peroxide. And the hydrogen peroxide will oxidize the colorless Nitroblue Tetrazolium dye, and the dye will turn blue, causing now the appearance of blue-colored structures in the cytoplasm of the neutrophil. But if the neutrophils have missing subunits of the NADPH complex, then they cannot generate hydrogen peroxide, and the dye is not oxidized, and it will remain colorless. Take a look at the neutrophils on the right side of the screen. You have their blue-colored structures in their cytoplasm, and these blue-colored structures are the oxidized Nitroblue Tetrazolium dye, and therefore that would indicate that the neutrophil can generate hydrogen peroxide because they have the complete subunits of the NADPH oxidase enzyme. Take a look at the neutrophils on the left photo. The dye in their cytoplasm remain colorless, and that's an indication that these neutrophils belong to a patient with chronic granulomatous disease. Just like in the case of Chediak Higashi, there is no known treatment for chronic granulomatous disease. So as future doctors, what can we do? Number one, give antibiotics, especially if we can identify infections in patients who are already known to have CGD. You can also give antifungal medications if you're entertaining possibility of fungal pneumonia. To lessen the formation of granuloma and to decrease their size, you can also give the patient corticosteroids. And for the patient to have competent or functional phagocytes, you can subject the patient to bone marrow transplant or hematopoietic stem cell transplant. And in the future, if it will be approved, you can also suggest to the patient to undergo gene therapy. The third primary immunodeficiency disorder affecting the phagocytes is Myeloperoxidase Deficiency. Myeloperoxidase enzyme is the enzyme responsible for converting the hydrogen peroxide into hypochlorite. Myeloperoxidase deficiency is an autosomal recessive disorder, meaning you need to inherit two abnormal genes from your parents before you will manifest the disorder, and men and women are equally affected. What I like about this myeloperoxidase deficiency is that majority of the patients are asymptomatic. Why? Please remember, myeloperoxidase is involved in the conversion of hydrogen peroxide to hypochlorite. Hydrogen peroxide alone is already a powerful toxic oxygen radical. That's why hydrogen peroxide may be enough already to protect our body. That's why in patients with myeloperoxidase deficiency, even if they cannot produce hypochlorite, they still have the hydrogen peroxide to protect them. That's why they tend to be asymptomatic. Now, if the patient has diabetes mellitus, there's a chance that the patient will have recurrent infection with Candida albicans, the causative agent of oral candidiasis or oral thrush. Take note of this. If you are a diagnosed case of myeloperoxidase, as long as you don't have comorbidities such as diabetes mellitus, you will remain asymptomatic. So meaning, this recurrent Candida albicans infection will only be seen in patients who are myeloperoxidase deficient and at the same time diabetic. As mentioned, patients with myeloperoxidase deficiency are most of the time asymptomatic except for those who have diabetes mellitus because they will have recurrent infections with Candida albicans, the causative agent of oral thrashes. So, as a future medical practitioner, if you will encounter a patient who is complaining of recurrent oral candidiasis and then you've learned that the patient has diabetes mellitus, one of the things that should cross your mind as a possible diagnosis is myeloperoxidase deficiency. Nitroblue Tetrazolium test can help us differentiate myeloperoxidase deficiency from chronic granulomatous disease. In chronic granulomatous disease, there is the failure to produce hydrogen peroxide. Therefore, the colorless dye will never ever turn blue. But in the case of myeloperoxidase deficiency, the patient can produce hydrogen peroxide. Thus, the dye will be converted from colorless to a blue-colored dye. And that ends the part 1 discussion of immunodeficiency disorders. Thank you for listening.